Good evening, everybody. On behalf of Merck, we extend our warm welcome for this meeting called as MedChats. Uh, but today's MedChat topic is vision for METex14 skipping patients in non-small cell lung cancer, and we are very privileged to have a very esteemed faculty with us today to discuss this rare but very important topic when it comes to non-small cell lung cancer. Uh, to start with, although we have a very large agenda to cover, and to start with, we have our first session today uh, that is on context setting on non-small cell lung cancer and rare mutation in India and epidemiology. And for that, we are very very privileged to have a stalwart in oncology, Dr. A.K. Vetsher, who is Chairman Medical Oncology and Hematology and Stem Cell Transplant at Medanta, the Medicity, Gurgaon. Sir has started one of the largest stem cell transplant program in the northern India. Sir brings more than 30 years of experience with special interest in cancer genomics, immunotherapy guidance, precision oncotherapeutics in addition to dendritic cell therapy and stem cell transplant. Sir has authored several peer reviewed articles and has been actively involved in clinical research and participated in over 50 international and national studies as principal investigator. And not only this, Sir was conferred the prestigious Padma Shri award by the President of India for his outstanding contribution to field of medicine. And it is our privilege, sir, to have you with us for today's meeting. And I pass on to you, sir. You can start your session.
Thank you, Sachin, for the kind words. You've been very generous. And in the interest of time, I think let's move on quickly. And it's a real an honor, Professor Nick, to be sharing this session with you and learning more about this rare mutation. All of us are realizing these mutations in the clinic. Can I have my first slide? Can somebody share the screen? So I will very briefly talk about NSCLC and rare mutations in India and give you just a flavor of the numbers, what we deal with. Globocan tells us that there are about close to 2.4, 2.5 million lung cancer cases globally annually. And India contributes quite a good number to that. That's about, you see on the screen, it's about uh, in excess of 80,000 cases. And the practicing oncologists would tell you that the numbers are actually more because this data capture is on account of about 10 to 12% of the population, which is covered in the major registries. And men, of course, it's a male preponderance disease, and it continues to be a lethal disease in India because a lot of cases are coming late in the natural history, and most of them are as would happen in many parts of the world, they are beyond the purview of any surgical effort. And next slide, please. And one can see the changes over the years. You know, you see the 2004 versus 2021, how the impact on the daily living and the number of years which are lost. And you can see that lung cancer in 2004, this was as per the per 100,000, this was number 10, and it has sadly climbed to number 1. And you know, the shift in many other cancers has happened. Some of them have stayed stable. Breast, oral cavity, leukemias haven't had major shift, but lung, one can see that the numbers where we are losing a lot of productive years, and these lives are getting impacted negatively. Next. The oncogenic drivers, one does know that north versus south, there is a difference as far as the numbers are concerned. Talk to most of us in the north, we would say that EGFR blend 30%, go down south 40-45%. And other mutations are almost in sync with what is happening globally or any other part of the world. ALK up to about 5%, ROS1, and other mutations about single digit 1 to 2%. And this is as far as the adenos are concerned. And KRAS, of course, you know, the G12C and others we are seeing, but most of them are non-G12C. And MET, in fact, all of us are getting that. The availability of the drug was an issue, but we were nevertheless treating them with other options. And now lately we have switched over to the specific MET inhibitors. And squams, of course, they do have their small but finite number of mutations which are seen. And most of us are today uh, testing almost all of our squams for any driver mutation, and especially those who quit long time back. Next. The molecular testing is a work in progress, and we have seen over the last 20 years how the shift has happened, and even the evolution of the testing has taken place in India, and the penetration of these tests is good. We have the just to Professor Nick, just to give you a flavor that it's not only the metropolitan cities which have access to it. Lot of other state capitals. There are about 25 states, 26, and add some of the other union territories. We have about 30 large states and other administrative areas, and they would represent about 30 to 35 large cities. All of them have access to testing, and most of the oncologists are testing today. And the work in progress, I said, it's not only in the testing, but also in the evolution of the drugs. And one can see on the right side of this slide how we are now spoiled for choices in specific driver mutation types. Next. I think that would be the last slide, one but last. And one can see that the actionable biomarker before first line therapy and throughout their treatment course. Now there is a need to test upfront. There is a need to test at progression. And with the advent of the liquid biopsies, things have become much easier. Life is much easier. But look at the proportion of patients with metastatic NSCLC in a US cohort who were undergoing prior to first line, 79, during or after first line, just 11%, and no biomarker testing, sadly, though a small proportion, but should happen in almost every patient with an adeno and squam as well. Next slide, please. I think I thank you. I thank Team Merck, Sachin, and everybody for this opportunity, and a great pleasure, Professor Nick, to be here on this program with you. Over to you, Sachin. Thank you.
Thank you so much, sir. As always, it was very crisp and to the point, and it was a brilliant context setting. And sir, we agree with the part that with the huge population which we have, rare is not rare in India. And with this, we move on to our second talk, our international faculty talk. And can I have the slide, please? Yes. Okay. And we are very privileged to have Professor Nick Pavalkis for the topic of meeting unmet needs of METex14 skipping non-small cell lung cancer. Professor is head of Department of Medical Oncology and also head of clinical trial unit at Royal North Shore Hospital, Sydney. After undertaking a PhD in anti-angiogenic drug development, Dr. Pavlakis has over 20 years of experience in clinical trials and new drug development in lung and GI cancer. He is current board chair of Thoracic Oncology Group of Australasia and co-chair of the IASLC Continuing Medical Education Committee, as well as he's supervising three current oncology PhD students undertaking translational research in lung cancer. Professor, a warm welcome to you, and once again, a thank you for joining this meeting and taking us through this very, very important topic in the field of lung cancer. Over to you, Professor.
Thank you very much, Sachin, and thank you much, Dr. Vade, and thank you for that kind introduction. It's a real pleasure to be a part of this meeting. I'm just going to share my screen. Very interesting to hear the epidemiology of lung cancer in India, and you're absolutely correct. With such a large population, the numbers that you have in India far and away exceed the numbers we see caseload in other parts of the world. So my talk was going to be looking at meeting the unmet need of METex14 skipping in non-small cell lung cancer. These are my disclosures. So as has been elegantly displayed already, lung cancer is no longer a single disease. In non-small cell lung cancer, the first thing you do when you see a patient is consider what subtype of lung cancer that they have. And we now have had quite extensive molecular profiling outlining a variety of mutations for which there are many therapies now available. METex14 skipping mutations occur in about 3% of patients. And a very small percentage will also have some point mutations as well. So it's very important, as has been highlighted already, that when you have a patient with lung cancer, that you undertake appropriate next generation sequencing to identify the oncogene target. And just a quick note on that topic, next generation sequencing is not all the same. I think you need to understand and know the assay that's being used. If you're going to collect fusions, then you need to consider an RNA-based platform. The MET receptor tyrosine kinase is a proto-oncogene which has several roles in tumor proliferation, apoptosis, motility, and invasion. Gain of function alterations also occur with amplification and protein overexpression. Specifically, the METex14 RNA splice acceptor and donor sites leads to exon skipping at the juxtamembrane, the bit just at the membrane itself. And METex14 skipping mutations are oncogenic in a variety of cancer models. A variety of therapies have been attempted over the years to target MET pathways. Those targeting HGF monoclonal antibodies targeting the extracellular domain of the MET TKI, but most of the drug development and the most successful drug development has been with the tyrosine kinase inhibitors, which affect the intracellular domain of the tyrosine kinase for MET. And what's interesting about MET is it's not unlike other oncogenes which tend to occur in non-smokers. METex14 occurs in older patients generally, regardless of smoking history. It can be smokers or non-smokers, and also male and female. The other thing that's interesting is that quite a large number of patients will also have a high expression of PD-L1 as well. We also know that METex14 skipping itself carries a poor prognosis, indicating aggressive behavior in patients with lung cancer. The other thing that's noticeable with METex14 skipping is the failure to obtain substantial benefit from conventional therapies. This cross-sectional data demonstrated here shows a very low median survival obtained with METex14 skipping mutation patients treated with immunotherapy as single agents, and similarly with chemotherapy, as opposed to using a MET inhibitor with an almost threefold increase in survival in patients who use targeted therapy as opposed to empiric chemotherapy. As such, guidelines, and this is the NCCN guidelines, propose that molecular testing should be standard in all patients with adenocarcinoma, and they also go on to suggest the same molecular profiling be undertaken in squamous cell populations, particularly on small biopsies where patients may also have an adenosquamous tumor. Now, the gold standard for a diagnosis of a METex14 is tissue-based next-generation sequencing. However, you can also undertake liquid biopsy where tissue is not available, where it would be considered risky or invasive to patients. Certainly not as sensitive in tissue as the tissue biopsy, but is as specific. In other words, a true result is usually a true positive result. The use of MET, I think I've shown you this slide already, but the use of MET inhibitors, TKIs, has shown a threefold increase in the survivorship compared with empiric chemotherapy, arguing that MET exon 14 skipping mutation patients should be treated with targeted therapy up front. The other thing I mentioned briefly in the earlier slides was the association of PD-L1 expression with METex14 skipping mutations, commonly co-expressed at a high level, and yet paradoxically, the benefit of seen with immunotherapy is relatively low. It's certainly not what you'd expect to see in a non-oncogene patient who has a high PD-L1, where the clinical benefit of immunotherapy is far more substantial. This cross-section analysis looks at pooled real-world data sets, looking at first-line chemotherapy, first-line immunotherapy, as opposed to targeted therapy with tepotinib from the VISION study, which I'll show you in detail in the coming slides. And you can see here that patients treated with immunotherapy have a far more inferior outcome for both progression-free survival, and in the same as seen with immunotherapy and chemotherapy in the schematic number B, where you can see the benefit was far more substantial with targeted therapy with tepotinib. Matched in direct comparison with real-world data set also has shown that survival is inferior with the use of empiric immunotherapy or immunotherapy and chemotherapy as opposed to targeted therapy. And the survival data shown here is the data that's seen in the VISION study, again, which I'll show you in detail in the coming slides. So despite the strong association with PD-L1, if you look at real-world data sets, and this is from the Flatiron Foundation Medicine data set in the US, median progression-free survival and overall survival with empiric immunotherapy is again relatively modest and certainly not of that magnitude observed with targeted therapy. And as a result of that, both NCCN and ESMO guidelines recommend upfront molecularly targeted therapy for patients identified to have a METex14 skipping mutation with either of the available agents, tepotinib or capmatinib. And although mentioned, it's rarely not used as often in the clinic now with the superiority of the other agents. Crizotinib is also a MET inhibitor that's shown to be active, as has savolitinib in China. So let's move on to the VISION study. This is the largest study undertaken examining MET exon 14 skipping mutations. It included patients who were elderly, also Asian patients, and it was line agnostic. It included patients in the first and second line settings. This schematic on the left is the study schema. It consisted of two cohorts. The primary analysis was in the first cohort A, and then there was a confirmatory cohort C, and that made up a total of over 300 patients. Tepotinib was administered 450 milligrams daily, and the primary outcome of the study was overall response rate and traditional secondary endpoints of duration response, PFS, and overall survival. If you look on the right, the demographics between the populations, the treatment naive and the previously treated populations, you'll see it's relatively similar, slightly older in the treatment naive. In terms of line of therapy in the previously treated, you'll see that quite a large number of patients had received more than 2 lines and further of treatment. And the dominant histotype was adenocarcinoma. Here, how were patients diagnosed in this study? 42% of patients were diagnosed on tissue biopsy. 21% were positive for both liquid and tissue biopsy for METex 14 skipping, and 36% were positive for the liquid biopsy alone, which was using the Garden 360 platform. The primary endpoint of the study was overall survival, and in the initial cohort, you'll see this was 59%. Median duration of response was over 2 years, and progression-free survival was just under 16 months, resulting in a median overall survival of just under 30 months. 90% of patients had received some degree of tumor shrinkage, as demonstrated in the waterfall plot you can see here. And this is the treatment-naive population. And in the previously treated population, you'll see that the similar waterfall plot in terms of efficacy, the order of magnitude, not quite as high as those who were treated initially, but still quite a healthy response rate of nearly 50%. Duration of response, not quite as long as in the patients treated initially, 10 months, PFS of just under 12 months, and the median survival of 20 months. In the main manuscript of the study published in the New England Journal of Medicine, they also reported on the the benefit of circulating tumor DNA. 51 patients had matched baseline and on-treatment biomarker sample with ctDNA. 34% had a molecular response. And of these 34 patients, 67% had a molecular response. And of these 34 patients, 79% had a complete molecular response. And there's a waterfall plot that I've highlighted with the arrow there showing the molecular response in the blood comparing to the imaging response above it. 34 patients with a molecular response, 71% had a radiographic response. What was also interesting is in the 10 patients whose burial allele frequency actually increased from baseline, even one of those also had an observed response. The other interesting observation is the prognostic impact of circulating tumor DNA. The patients who had a positive circulating tumor DNA, L positive on the left-hand side, you see actually did less well than those who were liquid negative tumor tissue positive. And the thinking is that perhaps the tumor burden being greater in those who are ctDNA positive reflects a poorer prognosis. The other thing is which patients do better. The patients who had undetectable ctDNA do best. That's the pink line on the right. Then the patients who had molecular response, so whose circulating tumor DNA actually fell. And then finally, those patients whose molecular tumor DNA actually increased during the study did the worst. They're the molecular progressors. But what about in the brain? We know that 18% of patients in the VISION study had brain metastases at baseline, and an additional 20% of patients developed brain metastases thereafter. The overall disease control rate in the brain was 88%. And 2/3 of patients had an intracranial response, and the median duration of progression-free survival in the brain was 20 months. And you can see the waterfall plot there showing a response in all patients in the brain. The other thing that is important to look at is the Asian subpopulation. These are the patients treated first line who are treatment naive. You can see the response rate is comparable to the overall population, 64%, median duration of response of 20 months, progression-free survival of 16 months, and an overall survival of over 32 months, which is quite substantial. The waterfall plot again shows nearly all patients had some degree of tumor shrinkage. In the previously treated populations, again, similar observations as in the VISION study, overall population response rate of 50%. The magnitude of benefit in duration response, PFS and OS was significant, but as you can see, not as substantial as the treatment naive populations. What about older patients? This analysis within VISION study looks at those patients less than 75 years of age and those greater than or equal to 75. If you look at response rate, just numerically slightly less in the over 75, but otherwise still quite good, and disease control rate of 75%. That is 3 out of 4 patients had disease control. When you look at duration of response, again, the curves overlap for the under 75 and those over 75, and similarly with progression-free survival. What about safety? The commonest side effect observed with tepotinib, and it is with any of the METex14 skipping mutation tyrosine kinase inhibitors, is peripheral edema, which is a class effect. As you can see here in the under 75, which is the purple chart, and the gray being over 75, there doesn't seem to be any difference in incidence pattern attributable to age. And you've got low-grade nausea, diarrhea, and other side effects, with the commonest being that of peripheral edema. In terms of the severity of side effects needing dose reduction, slightly greater dose reduction frequency in the elderly population and temporary interruption and overall discontinuation than the younger population. So how do we compare, I guess, how does the data for tepotinib compare with the other tyrosine kinase inhibitors, capmatinib being the most commonly used alternative? The next set of slides shows you a match-adjusted indirect comparison. There's a statistical methodology applied to comparing data in an indirect fashion. This is by no means a substitute for a randomized controlled trial, but the best we have in terms of looking at data side by side. This was reported by Dr. Paik, who's also the lead author of the VISION study. And we looked at the data in the vision study, cohort A and C, and also looked at the data in the geometry study with its own cohorts in both the first line and the second line setting. We also looked at data from savolitinib as well. So when we look at on the left-hand side, progression-free survival, the pink is unweighted and the green is weighted using a propensity measure. And then the purple is out of the geometry study, which is capmatinib. You can see there that both whether weighted or unweighted, tepotinib has a substantial increment in median PFS. And similarly with overall survival when you look side by side with capmatinib. In the second line setting, the same similar observations observed. Tepotinib whether weighted or unweighted, and numerically higher progression-free survival and also overall survival than in the individual capmatinib phase 2 cohort. Side by side, showing here, the sample size is larger in the tepotinib population in the vision study than the geometry study. Progression-free survival, overall survival was numerically larger, although the response rate was comparable between these two studies. But what's interesting there is the duration of response being quite substantial within the vision study population. What about brain metastases between tepotinib and capmatinib? This indirect comparison here, just looking at the patients who had brain metastases in these two studies, you'll see the response rate with capmatinib is over 50%, and the response rate, as I've already shown you, with tepotinib was 67%, with a disease control rate of 88%. So what are the choices that we have in the clinic today for treating patients with METex14 skipping mutations? Depending on which part of the world you're from, obviously, the choices are between tepotinib, capmatinib, and or in some countries, savolitinib, mainly in China. The data, as I've shown you, comes from the key studies, the vision study for tepotinib and the geometry study for capmatinib. I've shown you the CNS endpoints showing benefit. And then in terms of pragmatism, what's the difference between these? Tepotinib is only a once daily regimen of 2 tablets. There are 4 tablets twice daily for capmatinib, and there's a daily regimen for savolitinib. This pragmatic difference may be of value to some patients who you think compliance is important. Certainly tepotinib has a longer half-life, hence allowing for the daily administration. And it comes in a dose tablet of 225, so 2 tablets daily, as opposed to, as I said, 800 milligrams BD for capmatinib. It's the standard dose reduction for tepotinib is from 450 to 225. The standard dose reduction with capmatinib allows a little bit more flexibility from 300 twice daily to from 800 milligrams, 400 milligrams twice daily to 300 milligrams twice daily or 200 milligrams twice daily. What about the side effect profile across these drugs? As I mentioned on the earlier slides, peripheral edema is a common class effect with MET TKIs, affecting approximately up to 2/3 of patients. The severity is generally grade 1 to 2, but around 10 to 11% of patients will have grade 3 edema. The other interesting observation there is creatinine kinase, which is a tubular phenomenon, not a true impairment of kidney function. Other toxicities include mild transaminase elevation, fatigue, and hypoalbuminemia. Across the board, the discontinuation rate for all of these drugs is as low as 15% for tepotinib and up to 20% for savolitinib. Why do we get edema with these drugs? The mechanism is not entirely clear, but it's thought to be due to inhibition of MET in the vascular and lymphatic endothelial tissue, leading to capillary leak into the periphery. Other toxicities, as I mentioned, is increasing creatinine, which is thought to be a tubular phenomenon, biochemical abnormality rather than a clinical phenomenon, elevated transaminases being the other one, and hypoalbuminemia. Interstitial lung disease is relatively rare. When do these side effects occur? Edema occurs quite early. Certainly also the GI toxicities occur quite early. Creatinine rise also occurs early. But the edema, as you can see, is the longer lasting one, lasting up to 67 weeks in the vision study. Nausea, diarrhea, vomiting, when treated aggressively, tend to pass, and the creatinine increase tends to be transient as well. What do you do to help patients? First thing is being proactive up front. Educate the patient that edema is common. Look at simple measures such as elevation of limb and compression bandages. And in patients who are prone to edema or have pre-existing conditions, lymphatic massage should be considered. Otherwise, and this depends also on their comorbidities, creatinine and other functions, diuretics can also be considered. Because the edema can be substantial in some patients, affects their ability to wear footwear and to get around by adding weight to their lower limbs, it is important to keep a vigilance and manage this accordingly, especially for elder patients with comorbidities. So in summary, there has been an unmet need for patients with METex14 skipping mutations until the recent years. MET targeting tyrosine kinase inhibitors are now in the clinic and recommended as first-line standard of care for the treatment of patients with METex14 skipping mutations. Diagnosis should be sought with tissue, and if not available, then the blood-based NGS assay. Tepotinib has demonstrated robust and lasting efficacy in treating patients who are treatment naive, and also in patients who've been previously treated. And this is demonstrated successfully in the vision study, where benefit was also observed in patients with brain metastases, the elderly who are over 75, and also Asian patients. By indirect comparison, using this method of matched in AIC technique, tepotinib is shown to be numerically have better results than tepotinib, although that is not by a direct comparison. Conservative measures and dose reductions and interruptions can be used to proactively manage edema, in addition to supportive measures and potentially diuretics. Thank you. I think I'm going to end there. And I'll stop sharing my slides.
Thank you. Thank you so much, Professor Pawalkis, for that very, very insightful session and a comprehensive one on how to manage METex14 skipping non-small cell lung cancer. You've covered almost everything, starting from biopsy, available options, management of AEs, MAIC, and I'm thankful for that. What we will do now, we will move to our next session on case studies, and for that topic, the topic of case studies of early Indian experience with TEPMETCO, I will invite Dr. Darshit Shah. Sir is consultant medical oncologist, precision oncology and hematology from Sir HN Reliance Foundation Hospital and Research Center in Mumbai. Sir is also ex-assistant professor from Tata Memorial Hospital, which is a very esteemed hospital here in India, in Mumbai. Darshit sir, over to you. I'll just request team to share his slides. Yeah, sir.
So thank you very much. And Professor, it was very wonderful to hear from you. So now I'll be discussing regarding the Indian experience with TEPMETCO. I hope, oh yeah, just a minute.
Yeah. Darshit sir, you're audible. You are on mute right now. Perfect.
Correct. So we all know that we have been mutation, and associated with poor prognosis. So, MET exon 14 skipping is typically challenging due to comorbidities. So, in vision study, cohort A and C, the
Darshit sir,
median age was rate of 54.8%.
s- sir, sorry,
Yeah,
but your voice is breaking in between. I request you to switch off your camera so that it will use
yes,
less bandwidth and we'll be able to hear you clearly. Yeah, thanks.
correct, correct. Now is it better?
Yes, sir, it is clear. Thanks.
Thank you so much. So in the vision study cohort A and C, the median age was 72 years. Tepotinib had an overall response rate of 54.8 months in patient aged less than 75 years and 54.1 in patients more than 80 years. The disease control rate was 67.5%. Next, please. So I'll be presenting a compilation of six cases with met alternation. Median age was 54.82 years. There were three females and three males, carcinoma, and performance for 0 to 1. All patients received tepotinib 450 milligram active moiety once daily, and they were reviewed and discussed within a multi. Next, please. Correct. So I would just, I think the slides were provided from the Merck. The biopsy method used here was sol tissue biopsy. Just over there, the performance status was between 0 to 1. Standard use was tissue-based NGS for most of the patient. I think one patient was having doing what liquid biopsy. So here we can see met the case number 5. Here we and we have given patients tepotinib because the patients were maybe not fit or maybe elderly. So we have also seen patients, post EGFR progression, we have seen MET amplification. So we have used tepotinib in those. Next, please. So here I will be case who is a 83-year-old female with a MET exon 14 skipping mutation. The liquid biopsy was done. There was no history of ILD and MET exon 14 skipping mutation was detected. So pre-treatment scan is showing a mass, and the patient was started on
That's it, sir. We lost your voice in between. Uh, I guess Dr. Darshit is facing some technical glitch. Darshit, sir, can you hear us? Yeah, he has rejoined. Darshit, sir, can you hear us? Technology sometimes can be a problematic, I guess. Not a problem. What we can do, looking at the time right now, I will just wait for Dr. Darshit to join back. If time permits, then we can continue this study after the moderated session. Darshit, sir, again,
yes, yes,
yeah, can you hear us? We can hear you now. Yeah,
yes,
I'll
yes,
just
yes.
request to put his slides back. Yeah, sir. Thank you.
So this patient basically was started on tepotinib. Next, please. Please move to the next slide. Yes. See that mass almost disappeared.
Sachin, could I suggest that we have the panel discussion, and in the meantime, if it could be sorted out?
Yeah, I think so. Dr. Darshit, I guess there are some technical glitches and at your end, and we are not able to hear you completely. Maybe we can take the case study once the technical issue is solved at your end. Now I request the team to project. Yeah. So unfortunately, we couldn't hear the case complete. Although it was an interesting case, Dr. Dashit is from one of the he was assistant from one of the leading institute, and he has a very good experience with using tepotinib. We wanted him to share the case. If the time permits, we'll take that case after the moderated session. For that, now can you go back to previous slide, please? Yeah. Now we move on to our panel discussion that is on meeting unmet need in patients with METex14 skipping non-small cell lung cancer. And we are very privileged again to have Dr. Anita Ramesh ma'am with us, who is a senior consultant, Department of Medical Oncology and Pediatric Oncology at Apollo Specialty Hospital. She is also goes to Kaveri Hospital. Ma'am is a very well-known uh, well-known faculty in the field of medical oncology. She's been associated with many scientific events, and we are very happy to have you as today's moderator, ma'am. Ma'am, can you hear us?
Yeah, I can hear you. A very good evening to
Very good evening.
everybody, and nice to be here with all of you.
Yeah, and ma'am, would you like to introduce your own panel?
Yeah, okay. Thank you so much for the opportunity. It was nice hearing our Professor Dick's talk. Yes, Darshit, we missed you. And Dr. A.K. Ved, thank you very much for moderating the whole program. With this, we move on to our panel discussion. We have specialists all over India to join with us. Yes, Professor Nick P., Department of Medical Oncology, Royal Shore, North Shore Hospital, Sydney, Australia. Warm welcome, and we need your inputs. Dr. Arun Warrior, Senior Consultant at Astra Medicity, Kochi. Dr. Shivam Sinkla, and he is also a medical oncologist at Nanavati Max Institute. Dr. Darshit, hope you'll be able to put in your thought process during the panel discussion. He's from HN Reliance Foundation. And I think Dr. Arun Warrior is Arun Warrior, Shivam, Darshit. What about Indranil Ghosh
Yeah,
and Devarat?
next. Yeah.
Yes. Welcome, Dr. Indranil Ghosh, from medical oncologist from Apollo Gleneagles, Kolkata, and also Devarat Arya, Max Super Speciality, Saket, New Delhi. A good number of panels all over the country. Thanks to Merck for getting all of us together for today's night discussion. Let's move on. So with the first slide. Yes. Though I tell me.
Yeah, ma'am, just one thing, Dr. Devrat Arya, we got a call from him. He had some emergency. So he just requested us, excused us from he said that if the case is solved, then he's going to join to us. Otherwise, we have a panel. And again, we'll again check with Dr. Darshit if he's able to, because we were not able to hear him for the case. So we'll check that we'll able to hear him. Dr. Darshit, can we just have a quick mic check?
Yeah, Sachin, we'll keep it open. Both Darshit and Devarat can join and talk any point of time. Yes, we'll keep it open for them. Okay.
Thank you.
Yes. Yes, we heard about a little bit about the MET-exon skipping mutation. Yes, we have. It's now a mutation. It's an oncogenic driver, and I think all testing of lung cancer should include the importance and testing of the MET-exon-14 skipping in all patients with non-small cell lung cancer until otherwise proven. It is more likely in elderly. Adenocarcinoma is histopathology, and it has demonstrated efficacy in all the patients bearing this mutation. outcomes are numerically higher when we give the targeted drugs, and the response is relatively good. And we'll look into how the doctors out here and manage these patients. As we move on to the next slide, Dr. Arun Warrior, what is the percentage of mutation have you detected in your practice of just MET exon skipping mutation? Or have you started doing it in your practice? How you are going about it?
Yeah, actually, I'm sending an NGS panel or the 12 gene panel, which includes the MET also. So previously, maybe 1 or 2 years back, we were not much focused on that. Now we have therapies, and now we know. I think in the last, the percentages may not be 3, maybe 1 to 2% we are getting that.
You correctly said, we were sending, but we were not oriented in getting the test done. We did not have the results, but shortly when the drug is available, we are having the results. And I think labs are accredited, they know how to do. And be careful that you do in a lab which has an accreditation. Okay, and they have because the test, we should not miss the test, and the test is very important. Whether how is the test being done and what are the parameters used in it. Okay, as we move on to Dr. Shivam. Now, Dr. Shivam, quickly, suppose you have a lung cancer patient, adenocarcinoma stage 4, the patient is having a mass which is accessible by CT scan. You have done by intervention radiologist has done biopsy of this tissue. Now, do you wait for the mutation report, or patient is not in visceral crisis? And do you wait for the report? You do wait for the report.
So if the patient is stage 4, typically the turnaround time is about 14 days where I practice. So we typically wait until the patient is not in any emergency. There's no pleural effusion or impending liver failure. So I tend to wait for such patients.
Yeah, I think 14 days to 3 weeks is the average time all over India to get us the report. Now, question coming back to you, do you go for limited panel genes or you go for the extended panel? And how limited is your panel when you have lung cancer specimen with you, patient in front of you?
As of now, ma'am, 80% of the patients end up with a 14 gene panel and a PDL1 analysis. The rest 20% where cost is not a constraint, I go for a broader spectrum like a Guardant or a Foundation analysis. Majority of the patients do end up with a 14 gene panel and a PDL1.
Yeah, I do agree with you. Yes, instead of being a complete genomic analysis, which may not be needed at this point, what you said absolutely holds good. A panel and all the genes are highlighted here, starting from KRAS, BRAF, RET, MET, ROS, and EGFR, ALK. Are the common fusions we are looking into. Can we go to the next part of the slides, and we invite Dr. Indranil Ghosh to talk here. Now, Indranil, now if you have to wait for the report to come, and it's taking some time, the breathing difficulty is increasing, what chemotherapy drug would you start using at this point of time? Indranil?
Yeah, so it will be only chemotherapy. So like pemetrexed with platinum combination. And I won't add any IO drug at this point till the full genome panel is available.
You'll wait for, you start off with the proper routine adenocarcinoma chemotherapy. Now, if you see this slide, this patient comes with a report having the MET exon skipping mutation positive. The report has by chance came 2 years back. What drug would you have used?
So this report is available before starting any chemotherapy?
No, we are in 2024. I'm just telling you, we got a report of METex14 in 2022. What would you start? Patient is 2022. And then I'll come to you 2024. What will you start? Same patient.
Yeah, 2022 capmatinib was available. It could be arranged at that time, so that was one option. Otherwise, chemotherapy.
And if it is 2024 August sitting now, Andronil, what will you do?
Yeah, now I would recommend tepotinib.
Yeah, yes, fine. That's what it is. So if you see the FDA approved tepotinib actually, and for the treatment, it's way back in 2020, but the availability of the and 21 you got the approval. Whereas capmatinib, rightly Indrolin has said, first approval in 2020 and 2022. So hovering around these two stages, and we did not have access to the drug earlier, neither this drug. I don't remember even capmatinib also getting approval. What we used to do the chemotherapy, as well as coming back to somebody have to mute. There is a talk going on. Now coming to Darshit. Darshit, if you are there.
Yes, ma'am.
Yeah, suppose I did not have access to tepotinib and capmatinib. What drug I would have used?
Ma'am, I would have preferred crizotinib. Since we have some data like before the launch of tepotinib or capmatinib, I mean, my experience, I have used crizotinib for some patients. So that was I would just take. Otherwise, the chemotherapy was second option, ma'am.
Yeah, yes, so I do agree with you. Many of us have used crizotinib in this occasion and given with the chemotherapy, but then overall the results were not good. The chemo didn't do well, and most of the patients failed on crizotinib. Why I'm trying to bring them in the discussion is that there was an unmet need. Can you mute? Can you mute if they are not talking? Okay, so there was an unmet need to what drug, and then we have these trials available. Okay, and coming, Adarsh, continue with you. Just look at this trial. It got presented now, daily dosing of the MET TKI approval skipping. So what do you infer from this study? The study pattern is open in front of you.
Yes, ma'am, definitely. Ma'am, in METex14 skipping machine, according to the study, I mean, it is one of the best. I mean, I have used it for nearly 8 to 10 patients, and if you ask me specifically about this study pattern, I'm comfortable, ma'am, because they are using cohort A in primary skipping mutation, and cohort C is, I think, I mean, both are basically exon skipping mutation. They are using tepotinib, ma'am.
Okay, thank you. Yeah, coming to Dr. Arun, do you expect, is it mutually exclusive, this mutation, or do you have such reports of having EGFR ALK positivity along with it, or METex14 is exclusive?
There have been reports of both being that MET and EGFR can be positive in some cases, and sometimes the X114 and the amplification also comes together. So they are reported. But then means in my patients, the couple of patients I had, they were the only mutations. X1 was the only mutation. Yeah.
Yes, coming back to Professor, whether it is mutually exclusive or you do get a combined mutation as well.
The majority are usually unique, but you can get co-mutations, as has been highlighted and demonstrated. You can get amplifications as well as METex14. And I've seen an EGFR and an ALK as well. You're more likely to see, I think, the co-mutations in the non-smokers for EGFR ALK, recognizing that 50% of the METex14 occurs in smokers. So I think the smokers are more likely to be single gene oncogenes, whereas the non-smokers are more likely to perhaps have some rare incidence of co-mutations. And as you've highlighted, India's had such a large population, you may see more than I will in Australia with the co-mutations.
Yeah, thank you very much for the answer. Another question to you, because it's a little bit difficult, I also don't know. Okay, so the METex14 along with PDL. There are data coming up. Yeah, how do you go about it?
Yeah, look, that's a good point. And that's the data sets highlighted there showed that they don't do as well, the METex14 with PD-L1 high, as opposed to the wild type PD-L1 high that does quite well with single agent immunotherapy or combination immunotherapy and chemotherapy. I personally, before we had access to the tepotinib, actually treated patients with combination chemoimmunotherapy seen a mixed result. And some of the old case series before the real world data came out showed some patients did okay, some patients didn't. As a whole, what's consistent now is you don't see as good a result not for the magnitude of benefit, nor for as long. And that's why I think it's pretty clear now, if you have an METex14 skipping mutation, treat it with a TKI, and use chemotherapy or second generation drugs if you fail. But the PD-L1 certainly does not have the same benefit or predictive benefit with an immunotherapy as it does if you're wild type.
Yes, thank you. So oncogenic driver is maybe the main thing. Yes, immunotherapy can be present along with that. So coming to Dr. Shivam, so you have seen that this METex skipping was seen in the liquid biopsy tissue, and that's how it goes. And tepotinib was the drug given. Can we go to the next slide? As we asked Dr. Shivam, do you regularly send both tissue and liquid biopsy? Next slide, please.
Liquid biopsy, I am only hello, ma'am, am I audible? Yeah. So
Yeah,
liquid
I'm
biopsy I'm
listening to
only
you.
doing for difficult biopsies, which are not possible by tissue biopsy, and or on progression to understand the RNA-based mutations and fusion mutations. So I am not doing liquid biopsy upfront in majority of my patients. Only tissue-based.
Yeah, so tissue-based initially, second line, third line, yes, we do tissue as well as liquid biopsy, provided tissue patient is willing to give. Now, can we go back to the previous slide? Same question to you, Shivam. Do you do it in squamous cell carcinomas?
Yes, ma'am. I have to do an NGS in squamous cell because BRAF mutation is something we look for, and we know that smokers also have a high probability of MET mutation. So I kind of do it in all NSCLC now, irrespective of the smoking status, a complete genomic analysis.
Yes, I think you're absolutely right. Now, even many of the guidelines says, even because there may be tumor heterogeneity, adenosquamous component. So yes, we do pick up mutations as that. As we move on to the next slide, I will call Dr. Indranil. Can we have the next slide, please? Okay, so you just quickly in your patient profile, so for the METex or what do you think the characteristics of the patient would be in a real case?
I have got both males and females in equal proportion. Very small number, obviously, in my total experience, but I have got both males and females, mostly non-smokers, but sometimes smokers as well. And
yeah, do you think they are elderly?
Sorry?
Are they elderly? Because this particular mutation you see in elderly, that's what.
Yeah, elderly.
Elderly, median age around 60 to 70. You don't get to see in the younger population.
No.
What you said, the whole's correct, equally male, female, okay. And then smoking history is there or may not be there. Adenocarcinoma is histopathology. We go to the next, Darshit. Next slide. Okay, so seeing this NCCN guidelines, okay, and we have finished our histopathology testing of these patients. So you have got an adenocarcinoma, and if you see both sides, there is METex skipping is there to be done with the PDL1 in bilateral. So in squamous cell, have you detected any METex skipping?
No, ma'am. EGFR I have seen, but METex14 in squamous, I have not seen yet, ma'am.
Yeah, correct. So that's the schema, and I think we all discussed except that NTRK, and I think it comes in the NGS panel, which all of you alluded, and it's a part of testing, and this is the comprehensive panel. And what I wanted to say, a complete genomic profiling may not be linear upfront, but yes, definitely second to the third line. Yes, as we move on to the next slide, that should stay along. The next question goes to you. Which alteration do you look in your clinical practice? Do you look for the point mutation, splicing mutation, fusions, amplifications? What are we looking at?
Basically exon 14 skipping mutation predominantly, but when we do, we also look for amplifications because I have used T14 and a copy number of more than 10, preferably. And we have also seen responses, ma'am. Like a patient who are poor PS or elderly, we have used it, sir, ma'am. So both.
Yes. So, and the question again goes to you. How do you look? What test are you going to do? You have said NGS, but okay, just the bigger word. So how do you do tissue and liquid? We already discussed, Darshit, and molecular testing.
So, ma'am, preferably NGS. If not, then maybe a fish can also be preferred. So,
Yeah, you are correct.
cost
Molecular
coming
testing.
down drastically.
Mhm.
Yeah, cost coming down drastically, ma'am. I am doing NGS for all the patients preferably, ma'am.
NGS, which has DNA, RNA, both panel, and yes, that's the best way to go about, both in the liquid and in the tissue. Otherwise, you use the other methods. Okay. As we move on to the next part, we come back to Dr. Arun. Yeah, we come back to NGS roles. Good. Then you have the next slide, please. So if you see the RNA-based NGA platform and the DNA-based NGA platform, so there is always a better to do the complete paneling with the DNA and the RNAs, and RNA is difficult to do and not labs. So Dr. Arun, in your practice, would you like to know what is the methodology of the testing, or you just send the sample and wait for the report?
Yeah, actually, when we send for NGS, usually they call back and tell the yield is not good, the tissue is not there. Now we will go look for the look for RNA. So I think if the material is inadequate, they go for the RNA. We don't have any other option. So so that's how it goes in the NGS which I'm sending. And again about amplification, I don't think in the routine NGS panels they are doing that. That's what I understand. It's only, and as of now there is no guidelines also, so I'm not much bothered about it.
Amplification, but then amplification has it. We bring in Dr. Professor Nick to this. If there is point mutation amplification, do you use the drug or do you give it for testing?
I think the answer is yes, you can. Although the data was more specific to METex14 skipping, we do have studies, as you know, from Insight 2 for amplification, largely in the osimertinib resistant population, but we know tepotinib works there. And I think on principle, in the same way that we use oncogene in the point mutations for ALK-ROS1, etc., or not the fusions, but in point mutations for EGFR, I would use tepotinib for a point mutation. There are two common point mutations that you could find if you look for them. The incidence is really low, but it's still there. And if you have a mixed RNA DNA platform, you'll find them.
Yes, thank you so much for the clarification. Yes, coming to the next slide can we have the next slide, please? Where tepotinib once daily was a selective TKI approved, and it was used in the phase 2 VISION study, and where we looked into the response rate and the survival figures for here. Next, please. Can we have the next slide, please? Okay, and the VISION is the only clinical trial for MET TKI to prospectively enroll patients based on the liquid biopsy, preferably. But yes, we have seen the other study where both liquid and solid tumors. Now coming to Shivam, next slide, please. Okay, do you use, we have discussed with you that liquid biopsy for biomarker, and coming to, suppose this particular patient, there is no accessible tissue and the patient does not want any invasive procedure. What is the strength and limitation of your liquid biopsy? And first and the third question you have already answered. Second question, again, back to you, Shivam.
Ma'am, I think liquid biopsy has a lot of strength, especially when we want to monitor the disease progress, the mutation, because it gives us a fair idea of the VAF. So majority of the times we need to understand that if a tumor was EGFR positive before, especially in co-mutations, how's the VAF doing? And with the change of drugs, the liquid biopsy really helps us. There are good liquid platforms available today. Guardant has a very good liquid platform that we are using quite a lot. Sometimes because of the tumor heterogeneity, we've not been able to document mutations on the tissue biopsy. They tend to pick up mutations more frequently than the tissue. All the tissue still remains the standard of care.
Yes, thank you. Can we move to the next slide, and we'll have Indranil with us? what are your recommendations on these patients with METex14 alteration? So you have a biopsy report of all the tests, your scans are done, and now you're going to start treatment. Dr. Indranil.
Yeah, so I guess this question was already answered, that as of today's date, we are going to go with the tepotinib first line, and if not given in first line only chemotherapy, then second line also we can use. Any specific question?
Yeah, tepotinib is another drug. Why do you want to use this drug? That's why the question. We have two drugs with us.
Yeah. As we saw from Professor Nick's talk, that in the matched analysis, tepotinib seems to fare better. And in my clinical experience also, tepotinib is a better drug. And I don't think capmatinib is available now. I think it's off.
Yeah, but it has it, still approval is there. So that was the question asked, what would you use the drug? Can we go to the next question? Then can we move the slides? Yeah, so again, coming back, Dr. Indranil, 50 years, cough and breathlessness, PET done, performance status around 2, adenocarcinoma. This patient has a PD-L1 80, okay, percent, and MET exon skipping detected. We have already put this question to Professor. Yes, there is a probability of PD-L1 80. There is a mutation. What drug will you start for this particular patient? It's an 80% PD-L1, 80%.
Yeah, still I will go with MET-directed therapy, that is tepotinib.
Yeah, and then what do you do with the PD-L1? You just leave it now, or do you want to do it sequentially, or you want to start parallelly? Because that's a pretty high immunogenic tumor.
No, parallelly I won't use, but in the second line, that too probably with chemotherapy, not without.
Okay, with the chemo, with an 80%. Yeah, and can we go to the next slide, coming to Darshit? Okay, so you have started on chemo. We got that all we discussed. Now the chemotherapy is going on, and your PD-L1 is 80 or MET is positive. Dr. Indranil said he wants to go with the MET exon inhibitor. Now, how do you choose the things? What happens to your IO? IO is with it or afterwards, or IO chemo now, which is an option in second line, or only MET followed by at relapse IO? Dr. Darshit. Okay, if Dr. Darshit is not there, yeah.
Am I audible, ma'am?
Yes, I can hear you. Stay. The slide is on. Please see and answer.
Correct, ma'am. So, ma'am, I would be changing to MET inhibitor.
MET inhibitor, and you continue how many cycles? When do you do the scans?
Ma'am, after 4 cycles, maybe if the scan is showing PR, I will change to tepotinib, or maybe I would just, if NGS report is showing MET exon 14, I would not continue chemotherapy, because we have very good data, and why would we give more toxicity or chemotherapy to the patient? I would immediately shift to tepotinib.
Tepotinib and continue. Okay, can we have the next slide, please? So despite with the high PD-L1 expression, immunotherapy provides a limited benefit in the overall survival and PS outcomes in patient when you have a MET exon skipping mutation. So, and you see the median progression-free survival, okay, and when you give the MET inhibitors, it goes up to median is 12 months, and it's 2.5 years almost the OS benefit with the drug, because you are targeting the oncogenic driver mutation. As we move on to the next slides, subsequently we'll see the data showing that immunotherapy provides a very limited benefit as far as OS and PFS is concerned in these skipping mutations, and that is seen in the VISION trial and intent to treat population. The red line, 15.9 months in both the places, showing up definite privilege, whereas tepotinib is the drug of choice when you have a co-mutation existing together. as we move on to the next slide with the further data which is coming in, showing that the guidelines now recommend MET inhibitors. And I think all of us, we already discussed this point. This is just to highlight, if you have in the NCCN guidelines, those with protein skipping exon mutations, the first line is tepotinib and capmatinib. Please remember, capmatinib is still there in the guideline. That's why the question directed. Okay, and it is not that it should not be used. Yes, availability, other things becomes a issue, but still it is, and there is. They don't say don't use or don't this do this, but data says tepotinib is a better profile with toxicity and survival and response benefit. If we already discussed the first, I think Shubham already said, I would have used crizotinib if nothing is available, and that was all of us doing before. Similarly, when you come to the ESMO guidelines, tepotinib and capmatinib have demonstrated meaningful efficacy and holds at same level of recommendation for a METex14 skipping. Crizotinib has demonstrated potential efficacy to some variants, needs to be confirmed, and is to be used when you don't, when you run out of options. Yes, as we move subsequently to the next slides. Okay, we bring in Arun at the picture. Dr. Arun, which one do you prefer? Say everything is available with you.
Yeah,
Tepotinib,
so now the data is very clear. The clear one is tepotinib, and capmatinib anyway they are not marketing anymore. It's only on compassionate basis. And crizotinib we know is an inferior drug, so tepotinib.
Savolitinib?
We have to go to China, maybe.
Yeah, but the Chinese drugs, you're using everything from China. Okay, we can also get it. Some of these drugs are doing well. So this is also there, and results have been reported in literature showing quite good. Yes, but not in a bigger trial. We don't have data, but yes, it is in the choice to be preferred. Okay, but what you said is right. We go by you. As we move on to our next slide for further discussion. Okay, so this is the results of the treatment-naive patients in this study, and where the clinical benefit of tepotinib compared to capmatinib, and the overall response in the real-world data, 59 point versus the 67 point, and the duration of response 46 months, and the tepotinib-weighted population was quite impressive. Yes. Coming to Dr. Shivam, next, can we move on to the next set of data in the next slide? Next slide, please, and Dr. Shivam. Okay, what is the importance of intracranial efficacy in this METexon? And what is the rate of the brain mets in your practice? It's brain mets. Shivam, doctor. Dr. Shivam?
I guess we have lost him, ma'am. We can direct this question to
Indranil, Dr. Indranil, do you have any, how do you answer this question? That is the blood-brain barrier penetration of the METexon skipping mutation drugs. And have you seen, or what is the rate of brain mets?
Yeah, brain mets are not infrequent in this group of patients. And as in any other brain metastasis, brain mets will lead to a very poor quality of life unless controlled well. So controlling brain mets is of paramount importance, and around 20% of patients METex14 will have brain mets. So controlling them, and the drug with the best intracranial disease control rate has to be preferred.
Yeah, yes, what you said is correct. And if you see the literature, brain-bone pleural metastases are reported in METexon skipping advanced non-small cell cancer, as well as the sarcomatoid histology, which has a more propensity of these metastases is seen. And the clinical outcomes, yes, we have to say anything within the brain, because the blood-brain barrier is a barrier for many of the drugs to get into it. So we are looking for drugs which will penetrate, like when we do for the EGFR osimertinib. Yes, MET has a good penetration into the brain, and that makes it one of the drug of choice. As we move on to the further data and further bit of questioning, can we go to the next set of slides?
Ma'am, Dr. Shiva,
okay.
like
so the
back.
system.
Yeah.
Yeah, I've seen. Okay. Systemic treatment of brain mets and non-small cell lung cancer, 30% do have, that's what I said, and MET mutations are also associated. As we move on to the further bit of it, and that shows a promising intracranial activity with brain mets. And Dr. Shivam, have you put any patients on tepotinib with the skin intracranial mets?
So, ma'am, I've had no patients who have got a brain mets and MET mutation, but with very positive, I think patients would eventually do well.
Yeah, the
They
results are good. Yeah, response going up to 60%, and the months of survival is 1.5 years. Okay, so that makes it quite a attractive drug for us to use, Shivam. What you said holds good. And as we move into the further set of data in the next coming slides, we call in Arshit. What is the safety? Okay, or Shivam also can take this question. What is the safety of MET TKIs? And then Darshit further to on the same point. Shivam,
Ma'am,
the question is there.
ma'am,
Anything?
I think
challenge is the pedal edema. Yeah, Darshi.
Pedal edema. Any other safety issues do you face? Shivam, Dr. Shivam.
Ma'am, I've had severe challenges with the pedal edema. So when this was giving capmatinib, patients were not able to tolerate it. Tepotinib, I feel the pedal edema is lesser, but when we have used avimentinib also, the MET inhibition somehow gives terrible pedal edema, the skin rash. It's a difficult drug for certain set of patients. There's urea which happens. There is loss of protein in the urine. That's what I have experienced. Otherwise, when the patients talk.
Yes. Okay, coming to Dr. Darshit, what is your experience on the safety of the MET TKIs?
Ma'am, in my experience, they are usually tolerated well. But as already mentioned, like pedal edema is the one which actually causes, discomfort to the patients. But otherwise, they are usually tolerated well, ma'am.
Yeah. Yes, so that holds good with the, I think that's a drug, and we have learned over a period of time how to use these drugs, how to manage the toxicity. I think we got a ring telling us that we should stop, and I thank all the panelists, and I want to give the concluding remarks. Yes, METex14 skipping is an oncogenic driver, and the edema is a class effect of this, and many of the patients do have, they have a edema, they do have nausea, creatinine rise, fatigue, and hypoalbuminemia. And correctly, all of us have told us, if you see the discontinuation rate, tepotinib has much better than the capmatinib. And as we see the subsequent slides, that's the potential mechanism of the edema. And next, as we go on to the subsequent slides, the preventive measures, limb elevation, stockings, lymphatic massage, furosemide, regular monitoring. If it is grade 3 disruption, grade 4 discontinue, and dose reduction are some of the things. But the drug is good. Don't so we have to talk to the patient, encourage them, manage them. But if it is life-threatening, please stop the drug. Otherwise, we can manage with dose reduction, interruption of treatment. Next, we see the dose reduction stepwise. Real-world evidence suggests that these reducing the dose. Now, coming back to Arun, have you any experience in dose reduction for any of your patients?
No, actually, this dose interruptions was effective for one patient with edema. After that, she could go back to the full dose. That's what makes sense.
Yeah, with the conservative measure, you discontinued and restarted the drug. Okay, and that's the way I think all of us should be using this drug and not to call it off. And as we see the subsequent slides, if you can just roll down the next few slides and then we conclude the session. Can we have the next few slides? Okay, view on dose convenience. Yes, we have already discussed about this reduction, oral drug, discontinuation, restarting, conservative measures. Okay, and with this, we conclude. I think our time is over. So MET exon skipping is an oncogenic driver in a distinct population of patients. Almost 2% is the rate that we are looking at, usually older age, adenocarcinoma, no characteristics are there. Sarcomatoid histopathology is common and they are little elderly individual. Yes, please test for it because we have the drug, and better to test, send comprehensive, not the whole panel, but a limited panel where MET exon is included. NGS with DNA RNA is the preferred testing platform for these patients, and we have drugs. It's approved. Nipotinib and papamatinib both has improved ORR, progression-free survival, and overall survival. But from Merck, this drug, tipotinib, gives us a better half-life, 450 milligram dosing once daily, 2 tablets, and compliance is better. We have seen the dosing pattern is good, the overall response rate is higher, the median progression-free survival, overall survival benefit, and the drug is available also with us makes it an important medication in the treatment armamentarium. Yes, side effects, we know we have dealt with many of these oral tablets, and we should be aware, and we should educate the patient and manage it conservatively, and go for dose reduction and interruption and restarting of the drug to give the best results to the best patient. And thank you very much to all my panelists, the chairperson, the international speaker, and Mark for bringing us together today evening. Thank you very much.
Thank you very much, ma'am. As always, it was excellent moderation. You always ensure that you get the best experience out of our attending panelists. And I'm very thankful to all the panelists for their candid views and sharing their experiences for a broader benefit of our attending HCPs. I'm pretty much sure that the attending doctors will get insights and also a clinical guidance to how to manage the patients with METex 14 skipping mutation. Thank you very much once again, ma'am. With this, I move on to Dr. A.K. Vech, sir.
Thank you, Sachin. And
For the conclusion.
I don't think there is much to be said beyond what has been extensively discussed. We have seen the entire landscape of the driver mutations, particularly the MET14, and the clinical development of the drug, the efficacy, and very favorably impacting the brain metastasis. And of course, the TKIs are not a new story. All of us have been using these for the last 2 decades now and have gotten used to the side effect profiles and have progressively gotten smarter in dealing with the side effects. And that was very elegantly discussed by Professor and Dr. Anita as well. And I think the education of the patients and the families is paramount. We have had patients with edema. In fact, all patients treated by us, I think we have about half a dozen patients till now. Everybody has had edema, but we've gotten to manage that with all those measures which have been discussed. Also, the issue about tissue and liquid, the PDL1 story, so elegantly talked about. Therefore, today we have a drug where there is no doubt you have a skipping mutation, exon 14, you have the drug and the right way to go about. And I thank Merck again for bringing all of us together. Thanks, Professor. Thanks, everyone on the program once again, and hope to see you in person in India, one of these meetings. Thank you so much.
Yeah, thank you so much, sir, for summarizing the session. And on behalf of Merck, I would like to thank Dr. A.K. Vech, sir, for chairing this and ensuring that everything goes smoothly. Thank you very much, sir. Professor Nick Pawalkis, sir, for the wonderful discussion and also his contribution to our panel discussion. Dr. Darshit Shah, sir, for the case discussion. Ma'am, Dr. Anita Ramesh, for excellent moderation, and our expert panel of Dr. Arun Warrior, Dr. Shivam Singla, Dr. Darshit Shah, Dr. Indranil Ghosh. Once again, thank you very much for each one of you for participating in this event. And with this, we conclude today's discussion. Thank you very much, everybody. Thanks.